Assalamu alaikum, dear colleagues and students. Today we should discuss about hydronephrosis and we will begin it. Hydronephrosis and hydroureter common clinical conditions encountered not only by urologists but also by emergency medicine specialists and primary care physicians. Hydronephrosis defined distension of renal processes and the pelvis with urine as a result of obstruction of outflow of urine distal to renal pelvis. Hydroureter defined dilatation of ureter. These pictures you should saw in the normal kidney and distended kidney as a result of hydronephrosis. And in this picture, you should see ultrasound pictures normal kidney and the ultrasound pictures kidney of hydronephrosis. In this picture, you should saw a normal intravenous pyelogram with hydronephrosis and ran with of normal compared with pathologies. And in this picture, in the slide, you should micropreparate of urine systems. It's you should so hydronephration chains of kidney. Hydronephrosis, presence of hydronephrosis or hydroureter can be physiologic or pathologic, may be acute or chronic, unilateral or bilateral. Can be secondary to obstruction of urinary tract, but it can also be present even without obstruction. Obstruction of uropathy, functional or anatomic obstruction of urinary flow at any level of urinary tract. Obstruction of nephropathy, obstruction causes functional or anatomic renal damage. Thus, the terms hydronephrosis or obstruction should not be used interchangeably. Etiology and presentation of hydronephrosis or hydroureter in adults differ from the neonates and children. Anatomic abnormalities, including urethral walls obstruction and stenosis or at uretrovesical or uretropelvic junction, account for majority of causes in children. Calculi are most common in young adults. Prostatic hypertrophy or carcinoma, retroperitoneal or pelvic neoplasm, and calculi are primary causes in older patients. Hydronephrosis or hydroureter defined normal finding in pregnant women. Renal pelvises and calyceal systems may be dilated as a result of progesterone effects and mechanical compression of ureter at pelvic bone. Dilatation of ureters and renal pelvis is more prominent on right side than left side and is seen up to 80% of pregnant women. These changes can be visualized on ultrasound examination by second trimester, and they might not resolve until 6 or 12 weeks postpartum. Hydronephrosis can result from anatomic or functional process interrupting flow of urine. This interruption can occur anywhere along urinary tract, from kidneys to urethral matters. Rise in urethral pressure leads to marked changes in glomerular filtration, tubular function, and renal blood flow. Glomerular infiltration rate declines significantly within hours following acute obstruction. This significant decline can persist for weeks after relief of obstruction. Renal tubular ability to transport sodium, potassium, and protons and concentrate, and to dilate the urine is severely impaired. Extent and persistence of these functional insults is directly related to duration and extent of obstruction. Brief disruptions are limited to reversible functional disturbance with little associated anatomic change. More chronic disruption lead to profound tubular atrophy. Increased urethral pressure also results in pylovenous and pyelolymphatic backflow. Growth changes within urinary tract similarly depend on duration, degree, and level of obstruction. With an intranodal collecting system, the degree of dilatation is limited by surrounding renal parenchyma. However, external components can dilate to point of tortuosity. Acute as hydronephrosis, when corrected, allows full recovery of renal function. Chronic hydronephrosis, loss of function, is irreversible even with correction of obstruction. Animal experiments, if acute unilateral obstruction is corrected within 2 weeks, full recovery of renal function is possible. However, after 6 weeks of obstruction, function is irreversibly lost. Grossly acutely hydronephrotic system can be associated with lethal anatomic disturbance to renal parenchyma. Chronically dilated system may be associated with compression of papilla, thinning of parenchyma around calces and coalescence of septa between calces. Cortical atrophy progresses to point at which only a thin rim of parenchyma is present. Microscopic chains consist of dilatation of tubular lumen and the flattening of tubular epithelium. Fibrotic chains and increased collagen deposition are observed in peritubular interstitium. Causes. A multitude of causes exist for hydronephrosis, and hydroureter classification can be made according to level within urinary tract and the etiology is intrinsic, extrinsic of functional types of hydronephrosis. Intrinsic ureteral level causes can be as follows: uropelvic junction structure, vesical junctions obstruction, papillar necrosis, urethral faults, urethral walls, uretrovesical reflux, urethral structure, iatrogenes, and the blood clot. So, the continuous causes the benign fibroepithelial polyps, urethral tumor, fungus ball, urethral calculus, urethral endometriosis, tuberculosis, retrovacular urethra, retrocaval urethra. Okay, the causes functional urethral level as can be as follows: gram-negative infection and neurogenic bladder. So, causes extrinsic urethral level can be as follows: is the retroperitoneal lymphoma, retroperitoneal sarcoma, cervical cancer, prostate cancer, retroperitoneal fibrosis, aortic aneurysms, inflammatory bowel disease, ovarian vein syndrome, retrocaval urethra, uterine prolapse. Pregnancy, iatrogenic urethral ligation, ovarian cysts, diverticules, tubular abscess, retroperitoneal hemorrhage, lymphocele, pelvic lymphotosis, radiation therapy, and urinoma. So, it's a bladder. Intrinsic bladder level causes can be as follows: bladder carcinoma, bladder calculi, bladder neck contracture, cystostele, primary bladder neck hypertrophy, bladder diverticule. And the functional bladder level causes can be as follows: neurogenic bladder and vesico-urethral reflux. Intrinsic urethral level causes can be as follows: urethral structure, walls, diverticles, atresia, labial fusion, hypospadias, and epispadias. Extrinsic urethral level causes can be as follows: benign prostatic hyperplasia, prostate cancer, urethral and penile cancer, and phimosis. So, urinary tract obstructions. Obstructions is a medicine in urine tract, reduce urinary flow that impair renal function. Frequent even effect of partial or complete obstruction is dilatation of renal pelvic hydronephrosis. Obstruction of urinary tract are painful, need immediate. Okay. It's these slides you can see types and location. This is obstructions. As you know, as we'll discuss about left kidney or right kidney, cross-section of right kidneys, renal pelvis obstruction, ureteric opening and cells obstruction, urethra, and the bladder and the prostate glands. Okay, it's in the slide. You should solve the calculus in the congenital periodicity junction obstruction. Okay, as you know, and as I said, you should know types of obstruction: extrinsic stroma, inflammation, infection, hemorrhoids, and fibrosis. Intramural transitional skin cancer, fibrosis, inflammation, infection. Intraluminal calculus, blood clot, and renal papilla. Consequences of urinary tract obstructions: reduced glomerular filtration rate, reduced renal blood flow after initial rise, impaired concentrating ability, impaired distal tubular function, and post-obstructional uresis. Clinic features: symptoms vary depending on whether hydronephrosis is acute or chronic. With acute obstruction, pain is frequently present due to distension of bladder, collecting system, or renal capsule. Pain is typically minimal or absent within partial or slowly developing obstruction is with congenital uropelvic junction, obstruction or pelvic tumor. It isn't uncommon, for example, to see an adult who is known to have hydronephrosis due to previously unsuspected UPI obstruction. Relatively severe pain, renal or urethral colic, may be seen with acute complete obstruction, as with a urethral calculus, or when acute dilatation occurs after a fluid load that increases urine output to level greater than flow rate through our area of obstruction. An example of later problems occurs after during gynecology students with previously symptomatic and unsuspectable UPI obstruction. Site of obstruction determines location of pain. Upper urethral or renal pelvic lesion lead to flank pain or tenderness, whereas lower urethral obstruction causes pain that may radiate to ipsilateral testics of labia. With regard to renal insufficiency, patients with complete or several partial bilateral obstruction also may be developed acute or chronic renal failure. In the latter setting, patient is often asymptomatic and urinalysis results may be relatively normal or reveal only fever, white or red blood cells. Anuria may be a presenting symptom of patient. Also, urine volume could be reduced in any form of renal disease. Anuria is most often seen in two conditions: complete bilateral urinary tract obstruction and shock. Other less common causes of anuria is hemolytic urine syndrome, renal cortical necrosis, bilateral renal artery obstruction, presenting of rapidly progressive glomerulonephritis, particularly antiglomerular basement membrane, and antibody disease. It's a continuous clinical features. A history of hematuria may herald a stone or malignancy anywhere in any urinary tract. A history of fever or diabetes adds urgency to evaluations and treatment. A history of a solitary kidney is an emergent situation. Hydronephrosis may be developed silently without symptoms as a result of advanced pelvic malignancy or severe urinary retention from larger outlet obstruction. Bilateral symmetrical hydronephrosis usually suggests a cause related to bladder, such as retention, prostatic blockage, or severe bladder prolapse. In hydronephrosis, you should meet in pediatric hydronephrosis and hydrouretra. Fetal hydronephrosis is readily diagnosed finding on antenatal ultrasound examination and can be detected as early as 12th or 14th weeks of gestation. Also, renal pelvic dilatation is transient. Physiologists state in most causes urinary tract obstruction and vesico-urethral reflux are also causal. Most causes of antenatal hydronephrosis aren't clinically significant and can lead to unnecessary testing of newborn baby and anxiety for patients and healthcare providers. Physical with severe hydronephrosis, kidney may be palpable. With bilateral hydronephrosis, lower extremity edema may occur. Costovertebral angle tenderness on affected site is common. A palpably distended bladder odds evidence of lower urinary tract obstruction. A digital rectal examination should be performed to assess sphincter stall and to look for hypertrophy nodules or induration of prostate. In children, hydronephrosis physical examination, especially newborn, can help detect abnormalities such as genitourinary abnormalities associated with antenatal hydronephrosis. This includes the following. Presence of abdominal mass could represent an enlarged kidney due to obstructive uropathy or multicystic dysplastic kidney. A palpable bladder in male infant, especially after wounding, may suggest posterior urethral walls. A male infant with prime belly syndrome will have deficient abdominal wall muscle and undistended testes. The presence of associated anomalies should be noted. Presence of altered or abnormalities is associated with increased risk of congenital anomalies of kidney and urinary tract. A single umbilical artery is associated with increased risk of KU, particularly YIR. Investigations in this investigation, we should patient's medical history, the urine tests, general blood tests, as well as blood biochemistry, level of urea, creatinine, and urine nitrogen, straight abdominal of X-ray, excretory urography, retrograde urography, and you should so ultrasound pictures. In this slide, you should read some diagnosis of investigation and treatment hydronephrosis. Medical care. Role of medical treatment of hydronephrosis and hydroureter in adults is limited to pain control and treatment or prevention of infection. Most conditions require either minimally invasive or open surgical treatment. Second notable or two notable expressions are oral alkalization therapy for uric acid stones and steroid therapy for retroperitoneal fibrosis. The conservative treatment consists therapy for hydronephrosis is exclusively auxiliary for temporary relief of symptoms. The urologist prescribes, as I said, antibiotics, non-steroid anti-inflammatory drugs, and antispasmodics. Surgical treatment, complete restoration of urine outflow is carried out exclusively by surgery. For this purpose, the urologist carries out open plastic surgery of the ureters at the sites of narrowing, laparoscopic operation to eliminate defects, and stenting of the ureter without incision through the natural opening of the urinary tract. And pay attention, the choice of the specific techniques depends on the location of the narrowing, its size, cause, and individual characteristic of a particular clinical cause. And so, thank you for your attention.